Right. Good morning, friends. In this session, I'll be discussing about the topic carcinoma stomach, where I'll go with the first epidemiology, then I'll go with the risk factors. I'll be discussing about the risk factors bit of in detail. Then we'll go with the staging, and for the session, we'll be deciding about the next point. Okay. So the first thing written here is in the carcinoma stomach. Carcinoma stomach is the fourth most common malignancy worldwide. So if you look into the prevalence rate, or if you look into this, it is the fourth most common malignancy worldwide. What is the first, second, third? The first is lungs. Beside the lungs, on the lungs, above, you have a breast. After BC comes colorectal cancer. So after lungs, after lung, after breast, after colorectal cancer, you have the fourth position, you have gastric cancer. Is the most common malignancy worldwide. What is the first? I've told you. Second, third. Now, and it is the second most common cause of death worldwide. If you look into this, if you look into the cause of death in the world, it is second most common cause of death. Now, what is the first most common cause of death in the world? That is a lung, okay, lung cancer. Now, the overall 5 years survival of treated gastric cancer is 23%. So, the 5 year survival of a patient, if 100%, 100%, only 23% the overall 5 year survival for treated gastric cancer. For disseminated cancer, only 5% will live. Only 5% disseminated cancer. What is the most common type of gastric cancer? The most common type of gastric cancer is adenocarcinoma. It accounts for 95% of the cancer. Okay, 95% of cancer. Now, few other important points which we need to understand. The most common site of CS stomach. If you look into the most common site, it will be incisura. Okay, incisura. Uh, in India, if you speak about overall India, okay. In the western, if you look into western, it is a proximal stomach, where the common site of CS stomach in the westerns is proximal stomach. Most common site of CS stomach in India, it is at antral, that is a distal. If you in the pernicious anemia also, you have a proximal stomach that causes that position you have in CS stomach. Okay, so that's the basic points which we need to understand. Now, we need to understand the risk factors which are very important. Okay, in the risk factors, you can just remember there are 6 S. Okay, 6 S. 6S, 4A, right? What is 6S? S for salted, S for smoked, S for stored food, S for spirit, S for spicy, S for smoky. That means the salted, the more you consume the salted food, the high chance of CA, stomach. More you consume the smoked foods, okay, fried, smoked foods, that also leads to CA, stomach. More you consume the stored food, okay, or the less, in the sense like if you look into this stored food where there is lack of refrigeration, okay, lack of refrigeration that is stored, that also leads to the CA stomach. And the spirit can also lead to CA stomach, right? And spicy foods can lead to CA stomach. So smoking can lead to CA stomach. So these are the 6S which we need to understand. Okay, now the next important points. What is 4A? In the 4A, if you look into this, you have atrophic gastritis, right? Then you have adenomatous polyp. Then you have type A plate, and you have pernicious anemia. So, in atrophic gastritis, adenomatous polyp, type A blood, and you have pernicious anemia. They also lead, they can also cause the CA stomach. Okay. And the next point which we need to discuss here is we have, I've told you that has been divided, right? There is genetic factors where we have a nutritional factors. In the nutrition factors, I've told you high salt consumptions and nitrates play an important role. Nitrates, okay. Nitrates. What does the nitrates does? Nitrates is responsible for last change of gastric mucosa. So late in response for late changes in gastric mucosa. Nitrates and nitrosamines act in last stage of gastric carcinogenesis to metaplasia, right? Dysplasia, right? That's the first point which we need to understand. So nitrates and nitrosamines act in last stages of gastric carcinoma. They act in last stages of gastric carcinoma, uh, from where you convert to metaplasia, then dysplasia. Okay. So the most important risk factor for the carcinogenesis, which I've told, there is a geographical risk factor, not the hereditary, where the stay plays an important role. Okay. So the next points, we have the occupation. A person who works in rubber factory, coal factory, they have high chance of getting the CS stomach. Okay. If there is any previous surgeries, or for next before that you have infections like H. pylori, Epstein-Barr virus, they also play an important role in the CS stomach. In the previous surgeries, you have any radiations, or if there is an history of gastric surgery, history of vagotomy, history of treatment for maltoma. These surgeries, the previous surgery, like you have a radiation, you have a history of gastric surgeries, you have history of vagotomy, history of treatment for maltoma. These all histories like radiations, history of gastric surgery, history of treatment for maltoma, history of vagotomy, they also are the risk factors. They are also the risk factors for what? For the gastric carcinoma. Okay. So these are the main important points which we need to understand. Okay. So let us understand where exactly we are lagging. And you have to also understand alcohol also plays important role. Radiation I have explained, previous gastric surgery explained, cold and rubber explained, Epstein-Barr virus explained, family we need to discuss about it. Okay. So, and before going in the important point of genetic causes of CS stomach, we need to understand what are the protective factors. Okay. What are the protective factors? The protective factors are the raw vegetables, right? The raw vegetables. You have a citrus fruits. They play a vital role in the decreased risk for the CS stomach. That is raw vegetables, citrus fruits, antioxidants like vitamin A, C, selenium, zinc, iron, green tea. Okay, they all decreases. They have the factors which decreases the CS stomach. Okay. So now let us understand. You have a genetic factors. Okay, we'll be discussing about the genetic factors now. In the genetic factors, okay, we have an inherited cancer syndrome. The first thing you have is hereditary diffuse gastric cancer. What is the gene which is responsible for the hereditary diffuse gastric cancer? The gene is E-cadherin. Okay, CDH1. It is E-cadherin. And what do you do in this hereditary diffuse gastric cancer? They have these patients, these are very rare cases, okay? Hereditary diffuse gastric cancer. Uh, the mutation is in E-cadherin, CDH1, E-cadherin. It's very rare. But if the patient has more than 800% risk, okay? So it has so much, very rare. But if a person has, if a person has, he has more than look into this, I don't know exactly 800 or 80, but so much of high risk, okay? So what you do in that patient is we have a prophylactic gastrectomy is advised, okay? You're gonna, because he get a cancer, right? Prophylactic gastrectomy is advised. Next you have hereditary breast cancer. In the hereditary breast cancer, the mutation happens in BRCA1 and BRCA2. In the hereditary breast cancer BRCA1 and 2, you have one out of, if BRCA1 out of 40%, 40 people, you have 1% chance of getting this cancer, breast cancer. And BRCA2 out of 400, 1% has chances. So you have total 2 to 6% of chances of risk of getting the CS stomach. Then you have Lichen syndrome, where the mutation is in MS1 microsatellite. MS1 is microsatellite, where 1 by 400, that is 6 to 12 percent of risk. So you need to understand, okay, Lichen syndrome, that HNPCC. Then you have the other leaf Roman is, it is P53 mutation, where is 1 by 5000, where the risk is 2.8%, 2.8 or 2.8% increased risk is there. So you have total of hereditary diffuse gastric carcinoma, where is it is CAD1, CDH1 E cadherin that we have discussed, more than 80% of risk, that is prophylactic gastrectomy is done. Then hereditary breast cancer BRCA1 and 2, 1 by 40, 1 by 400, we have 2 to 6%. Or Lichen syndrome, where MS1 microcell 1 by 400 is 6 to 12 risk. Leaf Romanis, it is P53. Okay, Leaf Romanis, it is P53. What exactly happened in the P53? Leaf Roman is P53 is 1 by 5000. 1 by 5000 get of 2.8%. So these are the basic, and complete sake we need to understand. You have FAP, okay, and the gene which is APC, JPS, juvenile polyposis, and SMAD4, and you have PJS, you have STK11. So they are 1 in 2 lakh to 2 lakh 50,000. JPS is 1 in 1 lakh. FAP 1 in 20,000. 1 in 20,000. So the next point which we need to understand, okay, we have a second common cause seen in CDH mutation is lobular breast cancer. The affinity around some 60% of the patients, average 53 years. So if a patient has the CD1, 60% of the patient have this, you get this what you get the CA, okay. If you have a CA who have 60% can have the lobular breast cancer, the lobular breast cancer. So we have FAP, which I've already told you, that is an familial adenomatous polyposis. Then you have PJS, Peutz Jeghers syndrome, JPS, juvenile polyposis syndrome. Okay, juvenile polyposis syndrome. So that's a basic and the most important points. For the completeness sake, we need to understand in detail, which is already written. So genetic factors contribute up to 10% of all gastric adenocarcinoma. Hereditary gastric cancer is recently discovered caused by mutation of E-cadherin is seen. 80% risk of developing the adenocarcinoma. E-cadherin mutation is specifically seen with diffuse gastric cancer. And we even have a Lee-Frohman syndrome. It is P53 mutation, BRCA2, I have told you, APC gene mutation, HPNC. And you have a sporadic gastric cancer can exhibit overexpression of proto-oncogens like c-KIT, METK, E-cadherin mutation can also lead to diffuse gastric carcinoma in sporadic. Okay, MSA microsatellite, 23% of intestinal type gastric cancer. We're discussing P53, P60 are seen in both intestinal diffuse type of gastric cancer. Okay, in inactivation of fetal. That's all. So just remember the few basic points which can be asked. Okay. Okay, that's all for the risk factors. Next, let us continue the session. Thank you.